Good morning, everyone, and welcome. My name is Nicole Pratt, the project coordinator for the SPAN Empowering Women and Community for Leadership for Healthier Families project. We are excited to have you here at this summit that will take place today and tomorrow. The two-day summit will focus on topics that are about women's health and wellness and the effects it has on their families. In the chat box, just as a reminder, please put your name, your organization, if you're a parent, professional, or both. You can also use the chat box for comments or questions. This session is being recorded, and we will also have links of resources also placed in the chat box. And welcome. Jeannie?
Good morning. Welcome, everybody, and thank you for joining us today. This is a new virtual platform for us for this summit. We're doing it over 2 days, today and tomorrow, so we're very excited to be here. So I am Jeanne McMahon. I'm the Director of Health and Family Support Projects at SPAN Parent Advocacy Network. Today we'll have 2 presentations for you. The first one, Taking Care of Your Mental Health, presented by Dr. Stacy Doumas from Hackensack Meridian Health. And we will also discuss fetal alcohol spectrum disorder, FASD, and lead poisoning prevention, presented by our very own Nicole Pratt, and we'll talk a little bit about mindfulness and meditation. So without further ado, I would love to introduce to you Dr. Stacy Doumas, our first speaker. Dr. Doumas obtained her medical degree from Rutgers, New Jersey Medical School, followed by a psychiatric residency and fellowship in child and adolescent psychiatry at the University of Miami-Jackson Memorial Hospital. She's board certified in both psychiatry and child adolescent psychiatry. She's an associate professor and associate chair of education in psychiatry at the Hackensack Meridian School of Medicine at Seton Hall University, and a clinical assistant professor in the Department of Psychiatry at both Rutgers Robert Wood Johnson Medical School and Rowan School of Osteopathic Medicine. She is also on the advisory board for the Monmouth University Physician Assistant Program. Since 2007, she has worked for the Hackensack Meridian Health System at Jersey Shore University Medical Center, where she is the residency program director and the vice chair of education and research for the Department of Psychiatry. Dr. Doumas is an active clinical researcher and has been involved in faculty continuing education and medical education at both the graduate and undergraduate level throughout her career. She has been instrumental in expanding psychiatric education in the Hackensack Meridian Health System. Her areas of interest and expertise include medical education, physician and trainee wellness, women in medicine, autism spectrum disorders, and adolescent mood disorders and suicide. So thank you, Dr. Doumas, for joining us here today. We are very interested and excited to learn from you today.
Well, thank you all for having me today. I was very excited to be invited. I do a lot of speaking and teaching at the medical education level, but it's really exciting to be involved in activities and programs and stuff for the community. So I was very excited to be here today. And we're going to speak about like taking care of your mental health, but really from a women's mental health perspective and how taking care of our own mental health impacts our families and really impacts those around us. So let me see now. Now it's not letting me forward it. So let me see what okay, now there we go. Okay. So what we're just gonna, the agenda just to like set the tone of what we're gonna talk about is we're gonna talk about why it's important to talk about mental health specific to women. And we're gonna talk a little bit about some of the stigma that's involved in talking about mental health and mental health conditions and how we can work to overcome that even in just this short talk today. We're gonna talk about the impact of mental health conditions on females and their families, and talk about how we can prevent mental health conditions in women, and also how we can intervene to kind of, I always like to use the phrase, kind of be our best self, be the best version of who we can be for ourselves and our families. So that's really kind of what we're going to focus on today. So I'm going to give you a lot of kind of facts and stats and figures to get us started here. Some of these might be things that many of you are familiar with. Other ones might be new. It's kind of just to give some perspective to why this is so important that we talk about it. It looks like my formatting got a little messed up on this slide here, but I should be able to, still make the point. But just to point out in general, 20% of the population in the United States it was treated for a mental health condition in 2017. So 1 in 5 adults is treated for a mental health condition. That was 46 million adults in 2017. And 50% more women than men. So when you look at who's being treated, it is very frequently more women than men being treated. And so when you look at even a study that was looked at by the Armed Forces, they found that women were more likely to be diagnosed with both anxiety and depression than their male counterparts. So we're hearing that there's lots of, mental health conditions going on, and more women diagnosed than men. So why don't many women seek treatment? And first of all, it requires a lot of people don't seek treatment. There's a huge issue when we're talking about mental health with stigma. There's stigma for lots of people in lots of different cultures, and it is very different depending on if you come from, a separate subculture of the United States, you might even have different views than the general culture. But the general culture, there still is a stigma toward mental illness, which is definitely improving over time and has made significant advances. But very often, people feel too ashamed to seek treatment for a mental illness. But other times, there's just a lack of awareness on what is part of a mental illness and that it can be treated. For instance, people might feel that they get irritable all the time, or angry, or that they need to control things. And they might not realize that that's an anxiety disorder and it's very treatable. They might not realize that the symptoms they might have, they might think it's part of their personality, or that it's because, they've got a job that's too stressful. And they might not realize that there is a component of something very treatable there. So, and sometimes women experience different symptoms than men do. That is seen very clearly in severe mental illnesses like schizophrenia and bipolar disorder, that the symptoms might vary from females to males. So it's really important to understand the differences. And really what is needed is education about that mental illnesses are prevalent. We're talking 20% of the adult population is actually treated, and they're more prevalent than that. And the negative effects that having some type of mental health condition can have on both women and their families. And that there are so many resources available for the individual who's suffering. Meaning the resources aren't just like, here, go to a psychiatrist and take medication. There's all kinds of preventative well-being resources available. There's all kinds of, therapies, alternative techniques, support groups, and there's things like psychiatric treatment and medication. So there's a myriad of different resources, but we really need to kind of identify what's going on, realize that it is impacting us negatively, and then you can get to the intervention piece. So here's just some more facts and figures. First of all, underdiagnosing is a big problem. Half the patients who meet criteria for a psychological illness are not even identified as such by physicians and their doctors. So imagine if they're not being identified by doctors. For example, someone might be treating a patient for a myriad of physical symptoms and not realizing that the underlying scheme behind all of their physical symptoms is, a real underlying major depressive disorder that's causing them to have all of these other pain symptoms. But if we miss the depression, we're not going to help them get better globally. So if doctors are missing it, imagine that the actual person who's suffering and their friends and family are definitely missing it. Some things are more likely to happen in women than men. Women are 2 times more likely to have generalized anxiety disorder, which is one of the common types of anxiety disorder. And only half of people who have that are even treated. They're also more likely to be diagnosed with panic disorder and with specific phobias. Now, panic disorder does affect up to 6 million US adults, and it can be really disabling for some people. So with panic disorder is for anybody who's had a panic attack, when you have recurrent panic attacks and fears of having another one, that's panic disorder. And a panic attack is often seen in the emergency room by an emergency room doctor or a cardiologist, because someone will feel like they're having a heart attack or shortness of breath or some sort of physical symptoms. And they'll be treated, released from the emergency room and told that there's nothing, there's no cardiac explanation. It was a panic attack. But very frequently, those people then don't go on, for treatment for the underlying anxiety disorder. The prevalence of severe mental illness is 70% greater in men than women. And when we talk severe mental illness, we're talking about schizophrenia and bipolar disorder. But it still remains undiagnosed in a large percent of the population. And exposure to violence makes women 3 to 4 times more likely to be affected by depression. And that's one of the things that's really important to talk about, is because women are the majority of those who are exposed to sexual trauma or domestic partner violence. So they are going to be at a much higher risk of depression or post-traumatic stress disorder because of those exposures. And if it's been more severe or long in duration, it's going to be put in an either greater risk for depression and anxiety related to it. But because often of the shame associated with those things, or the control of the partner, or the role of the victim that often these women are in, it's very hard to seek treatment often for depression or anxiety, or even to understand that they have the psychological impact in addition to the physical impact that they might have. And when we talk about things like depression, the reason it is so important to realize we need to identify this and treat it is because depression is the second most common source of global disability. And this is worldwide. So just being depressed, it's not only impacting the person that's sitting home depressed, it might also be impacting their family, because a depressed mother might be, in bed, not wanting to engage with the family, not wanting to sit and have family meals, not wanting to, not feeling excited about, things the children are showing them. So it can affect bonding with young children. And with teenagers, it might affect ability to supervise them. So, but it also, when we talk about global disability, this also might mean not being able to work, unemployment, and the significant costs that come along with that. So just treating that depression can really impact not only that person as an individual, but can impact, from a global disability standpoint. And one of the things that we don't realize a lot is that women are often suffer from 3 or more comorbid mental illness. So very often when you see someone who's had a history of post-traumatic stress disorder, you might also see a major depressive disorder there at some point in their life. Or very often when you see someone who's been anxious for many, many, many years, at some point they might develop, they're anxious for many, many years. They might get involved in a relationship where there's domestic violence involved. Then they might start drinking alcohol excessively, and then develop depression when they feel like, that they just can't escape the situation. So very often there's a lot of comorbidity, and just treating one piece of the problem, like just treating, the alcohol abuse, is not going to solve it. You really need to address and treat all of it. And I think when you're working with women, if you're doing this professionally, I think it's so important to say, like, even if you're working with them from a standpoint of you're helping the children, and I know that you probably all do this already, say to them, how are you doing? How can we help you? Are you taking care of yourself? Are you getting treatment for yourself? And really try to, make sure that they're addressing their own mental health. Unfortunately, just by saying that, I'm not sure if it you know, it can be the starting point, but women really have to commit to making, you know, to getting that treatment they need. Women do wait an average of 4 years after the onset of PTSD symptoms to ask for help. So this is not something, you know, we're good at doing. And remember, sexual violence is the primary source of PTSD worldwide. So, I mean, that is really telling when someone waits that many years for treatment. And women do have a higher rate of developing PTSD after a traumatic event. So, women are 20%. So 1 in every 5 female who's been involved in a really traumatic event is going to develop PTSD. So when we ask a trauma history, we have to really think about, you know, what do we do after we ask the trauma history and they say, you know, the person says, yes, this happened. Because I know that even as a psychiatrist, when it comes to PTSD, the symptoms of PTSD are re-experiencing the trauma. So having flashbacks of it, or nightmares, or with children, you know, are they engaged in some sort of play or something where they re-experience it? Are they having like hyperarousal and symptoms that, but hyperarousal and mood lability and stuff, they really, really resemble other conditions. Like it might be things like anxiety, irritability, mood swings, depression, angry outbursts, trouble sleeping. And these cross over with depression and anxiety. So you really have to tease out if this is related to the past traumatic events, because very often, especially for people who've had multiple traumatic events, we don't always tease that out. And then they're having a PTSD that's just going undiagnosed. And we're trying to, like, you know, treat the substance use or, you know, treat the depression, but we're not acknowledging, you know, this big piece of their suffering. So I think it's really important to make sure we're asking people the trauma history and identifying it if it's something that, you know, we have in ourselves or in our families, and then making sure that we're looking for those symptoms and treating it. Because the treatment for PTSD, while you'll hear as I go through some of the other conditions, the treatment for a lot of mental illness can start with, you know, some alternative treatments like mindfulness and meditation and psychotherapy, which can either be individual or group. And for a lot of the anxiety disorders and depressive disorders, that might be what we call CBT, or cognitive behavioral disorder. And also then that there's medications. Well, PTSD treatment's a little bit more unique and a little different. The medications vary a little bit, and there's special types of therapy that they use. There's one special one called EMDR, which is eye movement desensitization. So there's some more unique things. So it's really important to know if someone has PTSD, so we can you know, really target it appropriately. The other thing that's really important to know is women are more than 10 times more likely to be associated, be affected by an eating disorder. And that would be, you know, anorexia is a common one, but also binge eating disorder. And binge eating disorder can sometimes, you know, be where people might start, and then it might move into something like bulimia or anorexia. And the reason that it's so important is because it can really impact their own eating behaviors, and it can impact eating behaviors of children as well, and well-being of children. But it can also really impact relationships and overall well-being and lead to other things like depression. And when we talk about specifically about anorexia, which isn't quite as common as things like binge eating, anorexia is the most dangerous of the mental health conditions, and people, which results in death often, either from the eating disorder itself or, you know, suicide. So it's really important that we're aware of eating disorders from early, because they're best prognosis when we identify them and treat them real early. And you can see the numbers there, that much more common in women, the eating disorders, than in males. So these are some of the things that are very different between males and females. And we talked about the stigma, and women are less likely to seek treatment. A lot of that is what we call internalized or self-stigma. And that comes with women. Sometimes now this probably doesn't come as a surprise to anyone, but women care what other people think of them often. So they might feel stigmatized that seeking assistance for a mental health issue is that people are going to think differently or have an opinion of them, or it's going to say something about them. And so that impacts how they feel about themselves sometimes, making them less prone to seek assistance with a mental health condition. Unfortunately, women rely often on opinions of the outside world for their self-esteem, and that can lead to this. So not only do we have the outside stigma coming in, but we have our own self-stigma that we put on ourselves as well. But with that said, women are much more likely to experience serious depression. And there are cultural differences in who's willing to seek treatment as well. The stigma of seeking treatment for mental illness is greater among women of color. African American women are half as likely as Caucasian women to seek help from a mental health professional, and Latina women are similarly hesitant to seek treatment. And the research shows that the culture of minority communities may be a hindrance because it puts women in a position of being strong and stoic, placing the needs of their loved ones above their own. And so really the way to overcome this is by the education that helping people realize that them being at their best state with their own health, and when I say health, I mean globally, physical and mental health, will help people better care for others and their families. So every patient, though, experiences mental illness in their own unique way. And this sentence right here is really why I tell medical students this all the time, is why I went into the field of psychiatry, because every patient we see, every person is extremely unique. And even though they might have similar signs or symptoms, everything impacts them and their family and who they are in unique ways. So whenever we're working with someone, we have to think about who they are as an individual, how they got to where they are, and how we can help them move forward. And that's why all of the treatments in psychiatry are so individual to the person. So I'm just going to go quickly through some different conditions that are more common in women. We talked a little bit about PTSD already. Depression is more likely in females than males. And among these, and there is a contribution of hormone levels that I think in the past was not, was like taboo to discuss. But there's a definite physical contribution that has to do with changing women's hormone levels that can cause both perinatal and postnatal depression around the time of pregnancy. It can absolutely cause premenstrual dysphoric disorder, where even if women don't rise to the level of having a full-blown mood disorder or depression around that period of time before they menstruate every month, they still might have irritability and a little bit of moodiness, and that is completely normal. If it rises to the point of premenstrual dysphoric disorder, we want to treat it so it doesn't cause impairment. But understanding that these hormone levels do cause, psychological symptomatology is important. And then there's obviously depression later in life related to menopause. Some of the common symptoms, as you can imagine, are feeling sad or depressed. But sometimes people won't say, I feel depressed. They'll feel lonely, empty, useless, hopeless, worthless. There might be crying, which they either out of, it might be that it's completely out of context or just too much for the given trigger. And sometimes I know people will tell me that, right before they menstruate, they'll cry over anything, and then a day later it'll be like, oh, what was that such a big deal for? So that's when you know it might be hormonally related. Not finding activities enjoyable, loss of energy, problems concentrating, any type of sleep impairment we like to look at. When we look at sleep, insomnia can have lots of different causes. Sometimes it's medical, like with sleep apnea. Waking up really early and not being able to go back to sleep is often a type of sleep problem that's associated with depression. Having trouble falling asleep and your mind with lots of worries is sometimes due to depression, but often due to an anxiety disorder. Sleeping too much. Some people who are depressed, they eat too much, they sleep too much, they have no energy, they kind of just want to be cocooned in bed. And they sometimes have a lot of physical symptoms. So if you're kind of achy and lots of physical symptoms. And irritability and easily angered, snapping at people can often be a symptom of depression. And obviously, if it gets to the point of self-harm, death, or suicide, that obviously becomes concerning. When we talk about perinatal depression includes any time related to the pregnancy. So it also includes the postpartum period. And 10% of pregnant women experience a mental health disorder, usually depression. Sometimes we see an underlying disorder that's already been there, sometimes bipolar disorder or psychosis, postpartum psychosis. One of the ones that I have found very common in a lot of women I have spoken to is postpartum anxiety too. A lot of people say, I wasn't depressed, I was just like cranky and anxious about everything and getting like, anxious about the baby. So postpartum anxiety is pretty common as well. And so the reason this is so important to address is because it impacts the woman's ability to function, but it also hinders development of the child and really can impact the bonding for the child. And the problem is greatest in developing countries where it can be in up to 20% of children. And some of the things if we're working with mothers who may have increased stress caused by things by, immigration, poverty, or exposure to violence, even here, that might also, increase their rate. So when you see those rates, they're pretty frequent. So this is definitely something we need to look for. And if we have, women and ourselves or family members that are pregnant, really be alert to these things. Because it's definitely, once you identify it, it's occurring for someone, then the conversation with their doctor is, what do we want to do to treat it? Because it's imperative, that we worry about both the mother's health and the child's health. And with postpartum depression specifically, that's when someone becomes depressed in the year after giving birth. And the problem is that a lot of women don't even identify it as what it is. And there are physical symptoms, physical components that absolutely contribute to it. Like there might be lack of sleep that can completely contribute to it. And there might be the hormonal factors that we talk about. And then all the psychological factors that come along with childbirth. So, but it's regardless of what's contributed to it, it's very important to diagnose it. I find it helpful with mothers if you, because very often, sometimes mothers will feel like that they either don't have time to worry about it, that it's a failure on their part, things like that. And them understanding that there is the physical, like the hormonal levels, their lack of sleep can all contribute to them feeling this way, can make it more readily treatable. And understanding that in order to bond with your child appropriately and to be there for your child and to take care of other children that you might have in the household and to be able to, have an appropriate relationships outside of your, parenting relationships, you want to feel your best. And the other thing to kind of separate it out from is postpartum blues, baby blues. Completely normal. They really happen. That's when a couple days after birth, usually 48, 72 hours after birth, someone's cranky, irritable, crying, and that's from the real quick hormonal fluctuations. That's completely normal. Happens in, I think it's like 85% of women. That's very common, and that usually goes away within a couple days. That's very common. Obviously, if someone's getting really, really, depressed during that point, or suicidal or anything, we need to appropriately look at it. But usually what that needs is just a lot of support and understanding on the person's own part that, okay, this will get better in a couple of days. The reason we worry so much about depression at any point, obviously, is it can cause the global disability that we talked about. It can cause, difficulty for the person themselves and their children. But we also worry because suicide is a reality for people who are severely depressed. In the United States, our overall suicide rate is 13.4%, and those are the usual means: firearm, suffocation, or poisoning. Very often, women make more attempts than males by using poisoning, which would be overdoses on pills. Women make far more attempts than but males complete suicide far more frequently. So we just looked at the overall suicide rate was approximately 13 in the United States. And here is the suicide rate specific to female. You can look at between 1999 is in blue and 2014 is in orange. So if we look at overall, which is all there, the suicide rate has increased between those two time periods from 4% to 5.8%. So still much lower than the rate in males, which is obviously a great big positive here. But it is increasing a little bit over time, specifically in non-Hispanic, whites and non-Hispanic blacks. So that is a concern. So we do need to keep an eye on it and make sure we're treating the underlying conditions of depression too, and things like anorexia. I talked about eating disorders to make sure we're staying on top of that. And this is the suicide rate by age group. So I'm kind of talking about, you can see it increases as people get older in most situations. And the reason I point that out now is because I'm talking about kind of women globally here, but it is important to point out that, that adolescent depression and suicide is very real. That these different conditions we talked about that peak depression peaking like during postpartum periods and then also again during menopause. There's definitely periods during women's lives that they're more susceptible to things such as depression. And it's very interesting sometimes to look at like kind of a lifespan mental health for females, because there are difficulties that are more common at different points in the lifespan. For example, eating disorders are more a young woman concern as well. So we're going to talk a little bit about anxiety now, because this is a very common mental health condition. So the main one we often focus on is generalized anxiety disorder, which is someone who is kind of has excessive anxiety for most days over at least 6 months. Now, if you think about generalized anxiety, this is someone who is a worrier. They're usually temperamentally a worrier since they're young, and they're a worrier. They kind of worry about more things than not, often very successful in many areas of their life. But if it's causing impairment, either in relationships, if it's causing people to feel a need for control and then get angry and irritable if they're feeling like they're losing control, you'll often see this. They can deal with their anxiety fine until someone has children, and then they have postpartum anxiety that gets bad, and then that's when treatment is needed. So you need to kind of look at anxiety in the context of whether it's causing impairment. Because a little bit of anxiety is not always a bad thing, but when it becomes kind of distressing or causing impairment, that's when it's a problem. I tell students all the time when I'm talking to them about lots of people have phobias, fear of flying, but most people can deal with their phobia without it causing much impairment in their life. It's really with anxiety, we look at it when it causes distress or impairment that we need to do something about it. And as you can see those rates, that 19% of all adults have reported an anxiety disorder in the past year. That's huge. And so it's 23% of women. So that means that almost 1 in every 4 women is reporting an anxiety disorder. Doesn't mean they're all getting treatment for it or doing anything about it, but I mean, that's significant. So we really need to make sure we're identifying them and treating them, because it can lead to so much better functioning for the women and their families, and maybe work and everything. And so these are some of the symptoms: that chronic irritability or nervousness, feeling unable to relax. If sometimes it might have physical symptoms associated with it, might have inability to concentrate. I told you that trouble falling asleep at night, and it might have some physical symptoms associated with it, like the stomach aches, like someone who's always a worrier, and they'll say like my stomach hurts when I worry, things like that. And some of the more specific conditions like social phobia, it'll really be specific to feeling rejected in social situations. Treatment is very similar for all of them and can either be medication related or therapy related, or things like mindfulness and meditation can also be helpful. Just quickly to mention body dysmorphic disorder. This is a condition where people think that there's something, that there's a defect on their body. Often with women, it has to do with a shape, maybe a shape of their nose, or on their face, or unwanted hair. And they just really, really, really focus on it. It often includes, rarely presents to a psychiatrist. Where we see it in women a lot is plastic surgeons to try to fix the perceived physical imperfection, but they're not usually happy with the results. With males, it's often seen as like the weightlifter at the gym who's never satisfied despite the fact that other people think he's very muscular and he does not. That's usually the difference in where you see it in males and females. It just can cause a lot of decreased functioning if someone's that obsessed about it. So it's worth pointing out. Eating disorders, we mentioned already. Women are twice as likely to be affected, which in the United States, that's 20 million women. These are some of the risk factors being related to someone who has an eating disorder. Chronic dieting can lead to an eating disorder. And I have a teenager who I'm seeing recently, and who was a high-level athlete for a while, and then stopped stopped getting as much exercise because she stopped with the sports, and then started gaining weight, dieted, up and down, and then had a recent kind of trauma, and this was always an anxious teen. And when the recent trauma hit, she just started restricting calories severely to a couple hundred a day, and really, really quickly developed an eating disorder with extremely poor insight. Because when I talked about treatment, no ability to understand that this was extremely dangerous and could be life-threatening if continued in this direction. So sometimes those kind of behaviors can lead to an eating disorder. The chronic dieting, the major change in how many calories are being burned by someone without a change in eating habits. Type 1 diabetes is, there's more eating disorders seen in children who have type 1 diabetes. A poor body image, so children who might be overweight and then are, that is being reinforced by friends or family. Having an anxiety disorder, being the victim of bullying or body shaming, and having a tendency toward perfectionism. And this girl that I was talking about, when she was an athlete, she was a really high-level athlete, and she's anxious and perfectionistic and does everything really well. So when there was a trauma that was out of her control, it was like a refocus of the perfectionistic, tendencies in a different direction. But with eating disorders, when they're left to go on for a long time, it really makes the prognosis far worse. So quick identification and treatment is very necessary. And the treatment usually needs to be multifactorial because insight, unfortunately, is sometimes poor. So we'll talk just quickly about bipolar disorder. Bipolar disorder is really when someone not only has those depressive episodes that we talked about, but also has highs. It used to be called manic depression episodes. I think when people say, like, I had a nervous breakdown, I often think they're saying, like, reporting something that might be bipolar. And it often has to do with someone flying high for a while, is usually bipolar 1. Bipolar 2 is less severe mood swing high, and often involves a lot of anger and irritability rather than maybe high energy, but mood is often not very high. So lots of mood swings, lots of ups and downs. And it can cause some major disruption, as you can imagine, in home life, family life, work life, if someone's having a lot of ups and downs. And unfortunately, because what presents first is usually depressive episodes, and they can be very severe depressive episodes, bipolar is often diagnosed very late because the manic part or the high part doesn't present early. They'll either have depressed episodes or mixed episodes. So even though the mood stuff might start as an adolescent, you don't see clearly the bipolar piece usually till someone's an adult. And the reason it's important to see the ups and downs and get a sense for that is because the treatment for bipolar disorder is very different than it is for treatment, because we use antidepressants called SSRIs, for depression, but for bipolar disorder, we use mood stabilizers. And for some people, the SSRIs can make the bipolar disorder worse. It can push them into a mania. So it can actually, make them worse. So it's important to identify the diagnosis appropriately from the beginning so the treatment can match the diagnosis. And bipolar disorder is one of the conditions similar to schizophrenia that really needs the treatment with medication, as opposed to for anxiety disorders and mild depression. You can start treatment with other things, but bipolar, especially when it's bipolar 1, really needs a medication component, so it really needs a psychiatric evaluation. Borderline personality disorder is important to point out, and I'm not going to talk about all the personality disorders here, there's many, but this is one that often resembles bipolar disorder, or it resembles mood swings, and it does 2% of people are affected by this, and it's going to end up being a lot of people who end up in clinical treatment, or requiring maybe lots of services and with a lot of needs, because it's people who do have a lot of mood swings, a lot of changes in behavior, and a lot of they're going to be in and out of relationships, feeling empty one minute, feelings of abandonment another minute. They might have lots of impulsivity, and a major risk factor for borderline personality disorder is early childhood sexual abuse and other types of trauma, and having a family history. And I know later you're going to talk about adverse childhood experiences, and these are all put people at risk for borderline personality disorder as they get older. One of the things I really like doing as a child and adolescent psychiatrist is really catching adolescents who really seem like they're on their way to developing borderline personality traits, and getting them into DBT, which is dialectical behavioral therapy. This is kind of the treatment of choice, the type of therapy that's the treatment of choice for borderline personality. And I like getting them into it early, not necessarily giving them the diagnosis, but getting them into it early so we can hopefully, help them, impact them in positive ways, and not have them develop the diagnosis of borderline personality disorder. And DBT is a type of cognitive behavioral therapy that's specific for people who might be making chronic suicide attempts, cutting behaviors, and this real instability in relationships and mood. And it's great. It's really a great therapy done in a group and individual setting. So, and you can start it, as I said, in adolescence. The other thing that's really important to talk about here is substance use and substance use disorders. And 15% of adult women have taken an illegal drug in the past year. When I read that like almost blows me away, because I do think that that's pretty significant. It is important to know, often these women who are using drugs are using them with males who are using drugs. But females and males they have extremely different bodies, which we just talked about. Their hormonal levels in women are different, which means differences in mood disorders. But research also shows that women can become addicted to drugs faster than men, even if they take smaller amounts among shorter periods of time. Often what you see with alcohol use disorders is that women will start later, and they'll have medical conditions much sooner than males. You'll hear about the male who drank heavily, for 30 years, who didn't develop difficulties, and you hear about that frequently. And then you'll hear about the woman who, when her children got into middle school and they didn't need her as much, started drinking a little too much, and 5 or 10 years later had cirrhosis and significant medical problems. So women do become addicted faster, and they do have significant medical comorbidity associated with substance use disorders. Sex hormones can also cause women to be more susceptible to the effects of drugs. They might have more cravings once addicted, and that might lead to more frequent relapses. So we also have to know that in the treatment, because we know that relapse is part of the disease. And obviously, if they use it while pregnant or nursing, they're putting the child at not only health risk, but they're putting themselves at risk of, continuing to have custody of the child, which is putting the child at health risk from the drug, as well as the danger of whatever situation they put themselves in, and then bonding difficulties if they are not able to, continue having custody of their child. So it's, so many different issues. And multiple different types of medication can also cause pregnant women to miscarry, including the opiates and stimulants. Stillbirth is increased with tobacco, cannabis, pain medication. So that has to be taken into account. Recovery is also different for men than women, because remember that when we're looking at women with substance use disorders, women often might need child care or parenting classes, or might need the parenting classes, obviously women and men will both need, but if a woman had just had a child, they might want a treatment program that incorporates child care into the program. And those type of programs that incorporate all of that are going to have a higher success rate than programs that do not offer such support. So the big question is kind of what to do. And I like these commercials here. These cartoons here. They're anti-anxiety pills, but I'm afraid to take them. And I think there's one on therapy there. Nervous little dogs face their fears at an anxiety management seminar, and they're all hiding underneath their owners there. So I do think that I mentioned as we went along here, that there's lots of different treatments for mental health conditions. Obviously, two of the main ones used by psychiatrists, psychologists, and primary care physicians are either medications, usually the SSRI antidepressants, the selective serotonin reuptake inhibitor antidepressants. There are things such as Zoloft, Prozac, Lexapro. We used to use Paxil. Those are medications that we use to treat depression and anxiety a lot. And therapy, usually individual, but in some situations, group therapy is utilized as well. And those are really great for things like depression, anxiety. We always usually say mild to moderate. You can either utilize the psychotherapy or medication, and when you're in the moderate to severe, the medication is really what's usually indicated. For the severe mental illness, like bipolar and schizophrenia, medication and a follow-up with a psychiatrist is usually the treatment of choice. And there are numerous treatment options available. The big thing that we go back to from what I said in the beginning is not being afraid to ask for help. So getting past that self-stigma of not wanting to ask for help, and that it says something about you if you ask for help, and being willing to ask for help. Psychiatrists are the ones that can obviously write the prescriptions. Psychologists or licensed clinical social workers can provide lots of different types of psychotherapy, and psychiatric nurse practitioners can also prescribe medication here. So if we're looking for the different types of treatment, those would be the providers who would be indicated. There's also a lot of other resources out there. Obviously, employee assistance programs. If someone doesn't have the mental health care, they can go through their employer. NAMI, which is the National Alliance for Mental Health, is a fabulous organization. And they've got a helpline that's 24/7, so someone can go online and look for that information. And they can provide a lot of local mental health resources, because most places have community mental health centers right in each county that can provide services, through all different types of insurance, including Medicaid and charity care. And then there are things such as support groups. So if someone has like postpartum depression, there's both in-person and online support groups. There's also hotlines for things like there's a National Suicide Prevention Hotline. So that can be, given to people or utilized if someone needs it. There's also lots of online resources. So if someone is, nervous about taking that step, there's lots of places that they can go and read and say, you know what, maybe I do want to read a little bit more about, do I have postpartum depression? And so that's one place people can start. Obviously, being able to say I need help is, one of the important things. The other thing I'm not going to talk about much here, because I know there's going to be a talk later this morning on mindfulness and meditation and good self-care, which I'm a huge advocate for good self-care, even though it's not always so simple. But obviously, becoming resilient, and resiliency is a skill that we can all develop in ourselves. And there's a million websites to go look up. How can I become more resilient? How can I overcome adversity? Because there is always, for all of us, going to be adversity in our lives. And there, for some of us, it'll be worse than others. But maintaining good self-care and building yourself up as a resilient person is one of the best ways to encounter mental health conditions when they come upon you. And so these are just obviously exercise, eating a balanced diet, and finding a job you enjoy. It's very important to surround yourself. Now, some of us may not always have that option, but surround yourself with a job you enjoy, with people you enjoy, and these are things will definitely help your mental health. I always say with relationships and stuff too, if you have a friend that every time you talk to them, you get off the phone feeling horrible, well then maybe you need to separate yourself and find friends that make you feel better. So you want to always be thinking of the basics when you're thinking about good mental health too. This is one online site, helpguide.org International, and they really go through 6 strategies to boost contentment and happiness and promote good mental health. Some of the things I had already talked about: investing in positive relationships that are friendly, engaging, and non-judgmental. And some of those kind of relationships are going to be the ones that say to you, hey, you don't seem yourself lately. You seem depressed. Have you thought about, tell me about it, and then maybe we can talk about what you can do about it, So you really want those strong connections. And staying physically active, avoiding stress that you can avoid, and sleeping well. Sleeping well is very, very important. And if you can't sleep well, figure out if it's a medical reason or something else, and figure out how to improve that in your life. And finding purpose. Now, whether that purpose is through work or volunteerism or whatever that is, but find that purpose. So this is a great website to start with for promoting good mental health. And really, when we're talking about it, I love this, that the knowledge is power, because I think it's that we talked about, identifying that that maybe there's something wrong and that you need to do something about it, and overcoming some of the challenges that we have that we feel to be strong, the nurturing caregiver, the one taking care of our family, friends, and communities, and saying, hey, you know what, I'm having a mental health challenge right now, and I want to have a fulfilling, enjoyable life too, and I can best help others by being at that place in my life. So I'm going to, figure out what's wrong, and I'm going to seek help for that. And that's really the important first step. And so I put up this picture of Wonder Woman at the end, not because I want to promote the women have to be so strong to overcome everything, but that I think this knowledge is power. And I think, and definitely not because I like the whole sex symbol that she portrays here, but I really think that the knowledge is power, and we can be our best selves and our strongest selves if we work from within, identify things, and really, work to get any treatment that we might need, and to help other women, in a non-judgmental way, whether we're working with them, whether it's our daughter or whether it's our client that we're working with, but to really, help each other and help us get to be our best selves. So that is all that I have, and I think I'm right on time.
So we do have a couple of questions in the chat box we want to have you ask. We got a little wiggle room before I do the next one. So I was
trying to avoid the questions by talking, but no, I'm joking.
I think there's some that could have been answered, but let me just. Okay, so if women who are going through postpartum depression repeatedly, does that mean she will be high risk for depression later in life?
Yeah, when you've had multiple episodes of depression, it increases your risk of future depressive episodes.
It's a yellow one. Oh, here it is.
So if you've had multiple episodes of depression, you are at higher risk of future depression. There are some women who might only have things, confined to the postpartum period. It is possible, but usually when you've had multiple episodes, you may be at more risk later on. And if you've had one episode of postpartum depression and you have future children, you are at increased risk of future postpartum depression. So
Okay.
that is something women have to be alert for.
Okay. Let me.
And I'll just add to that, what's important is that once you've had episodes of depression, some people, once they've had a couple, they say, I never want to go back there again. I will take medication forever and I never want to be there again. Other women will say, I feel better. I want off this medication. I've done therapy, I want to see how I do. And it's just important to really identify, hey, when I first felt depressed, this was what the beginning looked like. Because then if you feel that coming on again, you can, choose to intervene sooner rather than it getting, severe again the next time.
Right. I was looking for the other question. It had to do with Io, if you could help me find that other question. Somebody was asking about something the doctor mentioned. It was a definition to clarify.
I found a question, Nicole, while you're looking for that one. Do you have specific resources for women with these underlying issues that may be exacerbated by isolation and COVID?
Okay, and I didn't get into the whole COVID pandemic today, but obviously the whole COVID pandemic, I have a friend who's socially anxious, and she's like, this is like a dream for people who are socially anxious, because she's like, everybody has to socially isolate. For the rest of us who don't have social anxiety disorder, this has not been like a dream, and has obviously, especially if there's domestic violence going on, or even just, poor family relationships and stuff, this has been very, very stressful. For some people who have more milder mental health conditions, people have not been following up for treatment because it's either been unavailable or their worries about becoming sick have kept them away. So obviously, any of the things I talked about could be exacerbated by the current condition. And especially if you're an anxious person to begin with, and then it's like to wear a mask, to not wear a mask, wear 6 feet. This could really, really kind of really push anxiety disorders to the next level. Or if maybe you were just a little anxious before, this could push you into that. So I don't think that, I do on my next slide have some resources and stuff. I don't know if there's anything specific to COVID. I know that the American Psychiatric Association has great websites with things specific to COVID right now. So I would look there. But as far as, so that'll just give you more of a general sense on how COVID's impacting people. It's definitely increasing rates of depression and anxiety. I will tell you that. But as far as for an individual person reaching out for help, I would look toward, your mental health providers in your community for help. But if you're looking online for resources, I would go to the American Psychiatric Society. Just put in American Psychiatric Association and look at their resources. They've got some great stuff.
Okay. Okay. Here are the other. We'll do these last 3 questions. Define hyperarousal. Person in layman's terms.
Sorry, I was trying so hard. I hope there weren't a lot of other ones. I was trying really hard. I told you a lot of the talks I do are for grand rounds and stuff. Hyperarousal is when, I almost used the word hypervigilant too. So hyperarousal is just if someone's real keyed up on edge, if someone's had a past trauma, and they were attacked in their home, they might be more likely to jump at every time they hear a noise, or every time if they were sexually attacked, every time a male comes near them or touches their arm, they might jump. So it's kind of just that a heightened state of arousal where they might be more likely to, as I said, jump at something or kind of be keyed up.
Okay. People are taking. What are the chances of a bipolar mom's child to have anxiety disorder or depression, even if inherited? I believe that's what the question is.
I'd have to pull, I'm not good with numbers. I'd have to pull out my my slides. I do have child anxiety disorders, child depression. I have all those, so I'd have to pull out my slides. I will tell you that if you have a mood disorder that runs in your family, regardless of whether it's bipolar disorder or major depressive disorder, there is an increased risk of mood disorders running in children. Now, it's not like 100% of children with a mood disorder, 100% of parents with mood disorder have 100% of children. It's much, much less than that, but there is definitely, you know what I mean, a heritability. Usually not that the mood disorders don't usually carry over into anxiety, but there's very often people who are anxious are very often depressed too, so you see the two of them run a lot in families together.
Okay, so the last question, if there's any other ones, we'll send it to you. Do you have specific resources for college students with anxiety and depression?
Oh, college mental health, that's a topic in and of itself, which, and I don't even know what's going to happen with this COVID thing, because college mental health is becoming, trying to think if I have any specific resources though. You know, you're going to have to get that person's email and I will see what I can find for them. College mental health, some of the things that I will point out are, I mean, obviously, most children nowadays, adolescence has been very extended. Children stay kind of cocooned under their parents' care longer than they used to. They used to kind of like wave goodbye when they graduated high school. Now, so children often go to college kind of less prepared maybe than previously for kind of being on their own. So there's definitely a lot of, we do see anxiety, depression, eating disorders, substance use disorders. We see all of it. We see things like that because of structure. Maybe they were doing okay with like ADHD and stuff before, and now lack of structure, they're not able to organize and manage on their own. So there's definitely these things sometimes tend to get exacerbated in the college setting and can cause impairment, because whenever we look at any of these disorders, we're looking for distress and impairment. If they're causing that, then we're worried. But I can look specifically, I can't think of any. Sometimes where I go for anything with child and adolescent is the American Association of Child and Adolescent Psychiatry. ACAP is the acronym, AACAP, American Association of Child and Adolescent Psychiatry, and they usually have some great resources. And I would specifically look up, though, college mental health resources, because that's, you know, where you find that. And I think with all this, the COVID pandemic, I think we're going to see more anxiety and depression in younger adults, too.
Right,
Missing all their graduations and everything. And
thank you. Jeannie?
Thank you so much, Dr. Doumas. What wealth of important information you shared today, and I'm really happy that this session will be recorded on SPAN's YouTube channel, because I think that this is information that, you know, should be disseminated widely and broadly and deeply. So really, thank you so much for your time. And, you know,
thank you guys so much for having me.
Yeah, I'm sure.